Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. Warm welcome to today's event. Today's program is centered around preterm labor and protecting the fetus, which is at risk. We are delighted to welcome a galaxy of eminent stalwarts as faculty for today's event. But before I start with the scientific proceedings, as is usual, I would like to start by paying our respects and offering our gratitude to our seniors. Next slide, please. Next slide. I'd like to express my gratitude to our AMOG's office bearers. First and foremost, Dr. Rajendra Singh Pardeshi, our president of AMOG's. Thank you so much, sir, for your guidance, your blessings, and for all our academic endeavors, your wonderful inputs from time to time. Next slide, please. I'd also like to express my gratitude to Dr. Sujata Dalvi. Madam is the secretary of AMOGS, also an office bearer of the Mumbai Society, joint associate editor of Jugi. Thank you so much for your blessings and your support for all our scientific endeavors. Next slide, please. I'd also like to express my gratitude to the ICOG office bearers. Thank you, Dr. Lakshmi Shikhande, chairperson of ICOG, and Dr. Ashok Kumar, the secretary of ICOG. Next slide, please, for your blessings and for the ICOG credit points for the entire experience series, which we've been conducting since January this year. Thank you very much for your support and for granting us the ICOG credit points in a timely fashion. Next slide, please. We are delighted to welcome two very eminent stalwarts as chairpersons for today's program, Dr. Mandakini Megh and Dr. Anjana Khanna. And there'll be two fantastic speakers today, Dr. Haresh Doshi, sir, who's one of the senior most obstetricians in India, a doyen amongst teachers, and one of the foremost and most important people as far as obstetrics is concerned in India. We are also delighted to welcome Dr. Parag Biniwale, the Vice Chair of ICOG, who will be one of the other speakers. Sir is held up in an emergency and he'll be joining us very soon. But before we go on to the speakers, let me first begin by introducing the chairpersons. Dr. Mandakini Megh, madam, is the past chairperson of ICOG. She's also been the national vice president of FOXY way back in 2012-13. She is the longest serving member, the managing council member of Mumbai Society since the 1990s when I actually entered into medicine. So she's one of the senior most OBGYNs in India today. She's also international vice president of MWI Central Asia, vice president of AMWI, and she's somebody who's served on both sides, both from the government side as well as from the OBGYN's perspective. And she's helped hundreds of OBGYNs as far as the PCPNDT licensing issues were concerned, especially a few years back when machines were being sealed left, right, and center for small minor clerical errors in form filling, where there was no real PCPNDT issues that were really happening. And Dr. Mandakini Megh is always known as our person in government. She has been representing OBGYNs in government. She was Deputy Director for Government of Maharashtra, and she has published several books, not only in OBGYN, but also regarding rules and regulations, how they should be implemented, how we are supposed to follow them so that we stay protected and we do not fall prey to unscrupulous elements. She's received several awards from Mumbai Society, of course, the Ganatra Award, Mahila Gaurav Puraskar of the Government of Maharashtra, the the Shailaja Pandit Award for Women Empowerment from Mumbai Society, and several other awards to her credit. She's also contesting for the post of President of FOXY. She is the Mumbai Society's candidate for President FOXY this year. We wish her all the very best in her endeavor, and we know that she will continue to work tirelessly for ordinary OBGYNs like you and me, even after she gets elected. That's something which has always set her apart from everybody else. So, without further ado, I'd like to hand over to Dr. Mandakini Megh, madam, to introduce our first speaker. Professor Haresh Doshi, sir, has kindly logged in early and consented to be the first speaker for today. Madam, please unmute. You're muted.
So, good afternoon, everyone. And Pratik, thank you very much for that wonderful introduction of a common common obstetrician, like me, helping the common obstetricians of all over. That is my identification, and thank you very much. And this is my passion to keep on supporting, helping, run in the middle of the night to the, to help our obstetrician. I think, and I can't see anybody in the pain of, non-registration, sealing of machine. I think I'm very, very, passionate about that subjects. Thank you very much for inviting me as a chairperson, and wonderful introduction. So first speaker is none other than Dr. Haresh Doshi. We are, colleagues, friends, and long time association, and he is a teacher par excellence. And I know him as a wonderful friend, very warm and cordial human being. And Dr. Haresh Doshi, he is a designated professor, and I came in contact with him during ICOG visiting fellowship, visiting professorship, and we had a wonderful time with him. Now also he is a governing council member.
Seema.
Along with our Pratik Tambe and
Patient आ गई है?
Prasanna. So he is a
अच्छा, अभी
designated
आती हूँ,
professor,
5
HOD
मिनट में।
and OBGYN. He is a GS Medical College, Ahmedabad. He has the 36 long, prolonged experience of teaching. And as I said, that he is a teacher par excellence. He has published 7 books, booklets, 23 book chapters also, published 34 scientific papers. His faculty, I can see him at all the national, international congresses. He was a president of the Ahmedabad prestigious Ahmedabad Society, and also the SAGOG, and organizing secretary of AICOG 2000, chairperson of Practical Obstetric Committee, which is a subject is very dear to him. And he was a Foxy scientific chairperson, vice president, and I know him as a teacher, I say teacher of teachers. So Dr. Haresh Doshi, and he is going to enlighten us on a very important topic of the fetal neuroprotection, which is so essential in cases of preterm deliveries, premature, and we are going to listen to him. And I think so many of them are just eager to listen to you. So Dr. Haresh Doshi, the floor is yours for your talk.
So before sir starts, I'd just like to mention that I had the privilege of working with Dr. Haresh Doshi sir in 2019 when Dr. Nandita Palshatkar was the president of Foxy, sir was the vice president. And of course, Dr. Mandakini Meg is currently my zonal coordinator in charge at AMOC, so I report directly to her.
Thank you.
Well, thank you, Madam Mandakini, for introducing me in a complete detail. Basically, I'm a teacher, but passion for teaching, that's all sufficient. Thank you, Dr. Pratik, for inviting me for this prestigious endocrinology committee, right, your committee, right, AMOX, right, for this webinar. I must thank AMOX.
I don't want to interrupt, but Dr. Haresh Doshi, we keep on troubling him for our webinars also.
Yeah,
and he always keeps on obliging us.
So my other chairperson, Dr. Ranjana Khanna, lady giant from North India, right? A very, very senior obstetrician and right ground to earth personality, madam. And I must thank AMOG's president, Dr. Rajeshri Pardesi, my good friend, because we were colleague, co-vice president together in 2019 at Pratik Mansion, and also Madam Sujata Dalvi, secretary AMOG's. Also, ICGO chairperson, Dr. Lakshmi Madam, and Ashok Kumar, secretary, and all listeners or delegates who have joined in. The topic today given to me is fetal neuroprotection, our role as obstetrician. Before I start, I think it is not working. Sorry. How can I go for this? Can you see this full screen? Yes. Hello? Hello?
Yes, sir, it is full screen
we
now.
can see.
Please go ahead.
Okay, fine, thank you. So I go ahead. So with this background case history, real case at our place, I will start my right talk. We had one patient, male infant, 27 weeks gestation, born in reasonable condition, responded to resuscitation. There was a surfactant deficiency because baby delivered before the full effect of steroids. A stormy neonatal course, but baby cried and baby survived. So we were happy. What happened? something gone, something abnormal, right, in her routine activity, and scan was advised on day 21. Again, it was normal. Scan 21, normal. Then day 28, again some abnormality detected, and now this time the scan showed irregular echodensities in parietal parenchyma with multiple small cysts. Again, okay, mild CNS some injuries or some abnormality, but when scan was repeated on day 48, it was evident that large cysts appeared in that place of echodensities and proved case of cerebral palsy. So this is the scenario in modern times, ladies and gentlemen, that improving survival of premature infants. If you can see this, right, if I put here, right, at 27 weeks, 70% can survive with good NICU, right, level 3, level 4 facilities in our country nowadays in major cities, NICU. This is the survival rate. If you go to 28 weeks, the survival rate is almost 90%. But up to 30 weeks, it is a very premature baby, and there are high chances of, right, developing cerebral palsy. So this is a reverse graph. You can see cerebral palsy rates in premature infants. If it is, right, you can see this at 30 weeks, right, it is still 6 to 8%. After that, it goes very down. But before that, if you can see here at 29, 28 weeks, it goes high and up to more than 50% if you can save the child of 25, 26 weeks gestation, and which is a reality now. The babies are surviving, but then the cerebral palsy is a real problem in, right, bringing up that baby, right? So you know very well the identified roles of self: hypertensive disorder of pregnancy and eclampsia, preterm labor, and now the fetal neuroprotection. Sometimes in some patients, all go in hand. So it's a wonderful molecule, magnesium sulfate. Babies born of preterm deliveries have a higher rates of dying in first few weeks of life, very preterm babies. Greater risk of neurologic impairment, including not only cerebral palsy, cognitive dysfunction, educational difficulties, psychiatric disorders in childhood. All these problem adds to the problem of education and social cost. So this is very recently published Indian journal JOGI, right? So cerebral palsy, what is it? It is a global term for a heterogeneous group of, right, chronic non-progressive disabilities of the CNS, affecting what? Mainly the movement, muscle tone, and muscle coordination. So motor skill, right? Spasticity, rigidity, and no proper coordinated movements. Incidence in normal, right, population is only 2 to 3.2%, you can say. Higher incidence in preterm infants risk is inversely proportional to gestational age. Increasing due to increased survival, as I already told you, because of premature infants, and slightly higher incidence by, right, statistic is reported, no cause is found in male children and multiple pregnancy babies, right? So magnitude of problem, again the repetition of the same fact, but the last 2 lines I want to write you to read. At 28 to 30 weeks, as compared to normal full-term baby, 46-fold increase in cerebral palsy. Less than 28 weeks, 80-fold increase in cerebral palsy. So these, like see, we are doing more cesarean section, we are encountering more placenta egrita now. So like that, this is, right, because one side it is good that babies are surviving, on other side this is a problem that we have to tackle. It is multifactorial. Etiology exactly is not known, but multifactorial means total of these all factors will make more than 100%. But prematurity tops the list, heads the list, 42 to 78%. It can be IUGR, infection, APH, severe placental pathology, multiple pregnancy. But prematurity is the most important causative factor. Injury to brain can occur at any time. It is antenatal period or even prenatal period, rubella or infection, right? Blood or oxygen delivery to the fetus, which is reduced during pregnancy. Perinatal, again, the major portion is taken by preterm birth. There may be birth defects in congenital malformation, IUGR, or some sentinel events and multiple pregnancy. Postnatal, sometimes a trauma and cerebral infection can also cause. But the most important for our purview is preterm birth. What are these clinically and pathologically documented? These injuries are, it can be intraventricular hemorrhage, right, diagnosed by sonography very well, but when it is a white matter injury, it is usually diagnosed by MRI. The most adverse clinical CNS outcome is cerebral palsy. It can be also cognitive impairment, and again, I've told blindness, deafness, and developmental delay. So this is the CNS injury. Now I'm taking a break as per my routine style. You have to answer the most premature baby who survived. As on now, the world record. A, B, C, D, E, F. 19 weeks, 20 weeks, 21 weeks, 22, 23, 24. You have to SMS or WhatsApp on my number, and first two and answers, correct answer, will get the prize. Will get the prize. 98250 60125. Most premature baby, it was born in 2021. Now already 2 years passed, but that record is not again broken. So 19, 20, 21, 22, 23, 24. So please send me SMS or WhatsApp and I will courier you the prize. Okay, magnesium function, essential for cellular function, DNA transcription, hormone receptor binding, mitochondrial oxidative phosphorylation. Getting calcium channels, transmembrane ion influx, adenyl cyclase regulation. So it is involved in muscle contraction, control of vasomotor tone, cardiac also effect, and neuronal transmitter disease. Mainly we are using this, and you know this as an anticonvulsant. Block voltage dependent calcium channel is the most important. That's I have changed the color. NMDA receptor antagonist, Okay, so that is non-competitive, inhibition of NMDA receptor. We'll go to some details of this. Multiple magnesium, except again the way of function is not known. There are multiple theories postulated, Mainly is non-competitive antagonism of the glutamate NMDA, That is, you know very well that receptor. It increases because of this antagonism inhibition extracellular magnesium and block the calcium influx into the cell, which leads to blockage of neuronal injury. It has many other functions. Magnesium has stabilization of membranes, increases cerebral blood flow, prevention of large blood pressure fluctuation in the body and particularly in the brain, reduction in pro-inflammatory harmful cytokines and antioxidant effects. So, this is the most important, that is, of the magnesium, different, mechanism of action people have suggested, and most of them are now proved. So now we go to the evidences, from 2002 to 2008, 5 RCTs were done. The first 2 RCTs are here, American Journal and Lancet, So it was in 2002. They have other arm also, because magnesium is also tocolytic and anticonvulsant. So they have that studied also in that, not only neuroprotective, but then race 3 trials, Race 3 trials, you can see this is okay, I'm going this RCT, the same thing, but RCT, why it started? Because in 1995, the 2 scientists noted when they use Maxel for preeclampsia, eclampsia, HDP, they found when the babies were followed of that study, observation study, they had a less cerebral palsy. So they floated an idea that Maxel can be neuroprotective. 1995, almost you can say 30 years back. So, 20 years back. Then this RCT started. The first and second I already mentioned, Now this is 3rd, 4th, and 5th, where are very famous trials. ActoMag, that is Australian collaborative trial. BEAM study, that is from USA, beneficial effects of Maxel, and Premax trial from France. All have more than 500 or 1,000 subjects for study, and this was randomized controlled trials. What they told. They told that there is a reduction of brain damage or cerebral palsy, severe cerebral palsy. In Ectomag, it was 3.4% versus 6.6% in control. In Beam trial, it was also almost half, 1.9% versus 3.5%. Last column I'm reading. And in Premac trial from France, the death and gross motor dysfunction combined, it was 0.4% versus 0.9%. So almost half, whatever incidence was there, reduction of this cerebral problems or injuries or damage was half, and leading to severe cerebral palsy. So all these trials, 5 trials, okay. Now people did meta-analysis of the same 5 RCTs, meta-analysis. Individual trial were there, randomized control trial, but the results were good. But then meta-analysis also proved only one that Maxwell for neuroprotection decreases the risk of childhood cerebral palsy. It was Cochrane, it was published in Obstetrics and Gynecology, in American Journal, all 3 meta-analysis. Cochrane review. Maxwell significantly reduced the risk of cerebral palsy, substantial gross motor dysfunction at 2 years of age, and no significant effect on the baby, newborn, and the pediatric age, fetal, neonatal, and later on mortality. So it is safe, very safe for the baby. That was Cochrane review. Cochrane also said that is no significant differences observed for the maternal outcome. That is death, cardiac arrest, respiratory arrest. We are worried sometimes of a high dose of Maxwell leads to respiratory problem and cardiac arrest. No, never it happens. We are having a wrong fear and we are using it less, even for our preeclampsia. So it is not found in this Cochrane review told that no harmful effect on mother. Okay, so there was this positive conclusion that it is very effective, but at the same time, they also reported the strong evidence is lacking in 4 clinical issues, all 3 meta-analysis. That one, the gestational age below which this therapy should be offered. Now it is started that up to 30 weeks it should be offered. Some authorities say 32 weeks, 34 weeks, but up to 30 weeks everybody agrees. But still, it is strong evidence is lacking for that. Optimal loading and maintenance dose. As on now, 4 gram is a loading dose and 1 gram per hour is a maintenance dose. But people have used 6 gram loading dose, 2 gram, maintenance dose. So like that, but optimal dose, the strong evidence is still required. No information on the effect because all these studies were done to 2 years of follow-up of the babies. So no information on the effect of Maxwell on outcome beyond 2 years. Now the studies and the results will come because they are being followed up. But till they published this data, it was only 2 years of follow-up. And the last point of strong evidence is not happening is Maxwell has not been associated with decrease in other CNS problems. That is intraventricular hemorrhage and other adverse developmental outcomes like developmental delay, neurological impairment, blindness, and deafness. Only in cerebral palsy, it is well proved. But that is sufficient. Cerebral palsy is a big thing. And then we want to prevent that. So these things are also there where there is strong evidence is not leaking. This was the conclusion of the 3 meta-analysis. Cochrane, the Obstetrics and Gynecology Journal, and American Journal. So, India, Dr. Vandana from Western India, Vandana Bansal, she did this study probably in Nauroz Diwali Maternity Hospital, GS Medical College. 2 groups were there, 100 patients were taken, 50 on intervention, 50 on control. The infant who received Maxwell, they had a nice observation. They required less invasive mechanical ventilation. And there were more days free of respiratory support, meaning that the baby required less ventilator treatment and also the respiratory support. So no oxygen given to premature baby that we know one complication of premature heavy oxygenation of a premature baby to maintain oxygen level can lead to retinopathy, pigmentosa prematurely. So retinopathy of prematurity can be there. So that is decreased automatically because those who receive has less mechanical ventilator support as well as more days free of respiratory support. Also, the result was trained towards decreased risk of sulfate group for intraventricular hemorrhage. I'm sorry, neonatal hypotension and hypothermia, length of NICU stay also. So not only the ventilatory support, respiratory support, but also IVH, neonatal hypotension, hypothermia, which are more problems of a premature baby, and total length of NICU stay, all were less, right? But not on IVH was not on only less frequent, but less severe also. There is a good observation. Though, so they concluded this Indian study only, Maxel is a safe drug to use in until a woman at risk for impending preterm birth. It confers significant neuroprotective advantage to the neonate. It is time to start using Maxel in clinical practice for neuroprotective intent in our extreme preterm birth. Now, again, this is published in International Journal, but the Indian data, Indian study, again, 15 patients, for the study, 50 patients in one intervention group and control group. Study was done at Chidambaram, Tamil Nadu, and inclusion criteria was up to 34 weeks, right? Not up to 30 weeks. And what they found, the Thompson score. Thompson score is a clinical score for CNS injury in the babies, right? It is a total score from 0 to 22. 0 is a normal baby, good baby, and 22 is a very severe HIE, hypoxic ischemic encephalopathy. The Thompson score revealed that 60% of newborn had normal neuronal development, 38% had mild neonatal abnormality, only 2% had moderate. So no had a severe neuronal abnormality. So that score is a very good score for CNS, injury study, and that they proved. Like Apgar score, we have a asphyxia score, like Thompson score used for that purpose. So they concluded that magnesium sulfate given for fetal neuroprotection before preterm birth avoids cerebral palsy and lowers the risk of combined fetal infant death or cerebral palsy. Not only cerebral palsy, but death also is reduced. Again, an Indian study. Okay, last and second brain teaser. The world famous personalities, but not prematurely born. They were, the only one person, right? He was a full-term born. All others are preterm. So you have to again send me the right answer by WhatsApp or SMS 98250 60125. You have the choice of Sir Isaac Newton, Sir Winston Churchill, Mark Twain, American writer, Albert Einstein, scientist, Napoleon the King, John S. Kepler, the astronomer. All great personality, but all were preterm. Only one was not preterm. Please send me the answer. The first two answers received on my mobile, SMS or WhatsApp, I will courier them the gift hamper. Okay, so from this evidence, now the big academic institutes came with the guidelines. So Australian guidelines, you have ACOG, SOGC, NICE, FICO, and WHO, all. So that guidelines are, you can see, the almost after 2010, recent. So what is the Australian guidelines say? That is, they say in women at risk of early preterm infant birth, Maxel for neuroprotective effect of the fetus, infant, and child is grade A. Grade A. Gestation age should be less than 30 weeks. That is grade A. Dosage, they have not put the grade A, but it is also evidence that 4 gram IV loading dose, 30 minutes, and followed by 1 gram per hour maintenance infusion till birth. ACOG opinion, right? The available evidence suggests that Maxel given before anticipated early preterm birth reduces the risk of cerebral palsy. No official opinion can be given of the gestational age. From their analysis, they did not give the gestational age cutoff. As I told you, some meta-analysis also told that the strong evidence is lacking. But here also, they have not given the opinion, ACOG, but they have recommended it. Now, SOGs, they have come, Canada. They have come with good points. For women with imminent preterm birth up to 32 weeks, antenatal Maxel should be considered for neuroprotection. Level 1A evidence. Level 1A evidence. Also, they have said that there is controversy about upper gestational age. Antenatal should be considered from viability to almost 32 weeks, right? Grade 2 1B evidence. If antenatal Maxel has been started, tocolysis should be discontinued because Maxel is also tocolytic. You will add to the side effects rather than having effect. So other tocolysis should be discontinued. Level evidence 3A. They said that is like in a steroids, after 2 weeks, we give rescue steroids for preterm, right, for respiratory problem. But here there is no good evidence, insufficient evidence that repeat course. Suppose after 24 hours you stop and the baby does not deliver. After 3 days again you think there is a preterm labor. There is insufficient evidence that a repeat course of antenatal Maxel should be administered. Okay, now should delivery be delayed to give Maxel course? Delivery should not be delayed if there are maternal or fetal indication. This is only one part. If fetal distress is there, you have to save the baby first, life first, then think of cerebral palsy. Like mother complication, you have to terminate that pregnancy. Don't wait for Maxel to happen. Like we wait for steroids to happen, right? Sometimes we give tocolytic with steroids. Here it is not recommended. Maxel, right? If you can give it, give it. Otherwise, right, don't stop the labor when it is, right, indicated. Okay, recommended dose, they have said that 4 gram IV loading dose, 1 gram same. It should be given until birth or 24 hours, whichever comes first. If delivery happens in 13 hours, 16 hours, stop it. But if it does not happen, you stop it at 24 hours. Maxel should be started ideally within 4 hours prior birth. So when it is an active preterm labor, imminent, you have started it. If 4 hours are there with you and then baby delivers, the effect will be good. Even if it is not 4 hours, you must give it. The guidelines suggest, but ideally it should be before 4 hours. Grade 2, level 2B evidence. NICE also says same 2015, less than 30 weeks, recommended. 30 to 33 weeks, consider, think and give. But up to 30 weeks, always give. FIGO, our right international body, good practice recommendation that they say that viability to 32 weeks, again recommended, blue font, 32 to 34 weeks, considered, right? Maxel should be administered regardless of the right cause of preterm birth and number of babies in utero. Preterm delivery can happen due to many reasons. Whatever may be the cause of preterm birth, you must give Maxel. When birth is planned, Maxel should commence as close as possible to 4 hours, already told by SOGC that, right? And even if it is expected to occur sooner than 4 hours, Maxel should be administered, is still likely have some advantage for baby. Only thing, the drug should be stopped after 24 hours. Again, told you, right? WHO says strong evidence, right? Magnesium sulfate is recommended for women at risk of imminent birth before 32 weeks, right? For prevention of cerebral palsy, right? Single or multiple pregnancy. So, ladies and gentlemen, right? In summary, Maxel is recommended for neuroprotection of the fetus of a very preterm birth, regardless of the cause and the number of babies. Recommended from viability, if you consider 24, 26 weeks to 30 weeks, consider up to 30 to 34 weeks. Should commence more than 4 hours before birth. Also administer, even if the time is less with you, you should give it. Loading dose, most authority agree 4 gram in first half an hour, and then maintenance dose 1 gram per hour. Stop at 24 hours at birth, whichever is earlier. Monitor Maxel as per routine. That is how to monitor. Like your preeclampsia, 4-hourly intervals, vitals, you can use it, the urine output and knee jerk, so that you can do it. Insufficient evidence for repeat course significantly reduces pediatric mortality also, not only cerebral palsy. That is proved. The intracranial hemorrhage and some other things are blindness, deafness. There is no very strong evidence. But this is a strong evidence that mortality also decreases, not only cerebral palsy. That is the irony of situation. Our country, despite clear benefit of Maxwell and despite the established superiority of Maxwell in management of severe preeclampsia, eclampsia, preterm labor, it continues to be used suboptimally in India. That is a bad thing. So people are worried about side effect. See, I can recollect my experience also when I was a registrar in 1984, almost you can say now 40 years. Then Maxwell was new for eclampsia, and I took the permission of my consultant and I started. But when I gave the dose, there were my colleagues who were lined up to take the Niger. They were thinking that it will cause toxicity, and they were all bent upon taking Niger, that it is there or not, it is there. But then after a couple of years, everybody started using Maxwell as an anticonvulsant of preeclampsia. So new things always have some time to settle, but this is very well molecule and very good, not only for preeclampsia, preterm labor, tocolytic effects, but for prevention of cerebral palsy. Okay, thank you very much. Thank you.
Thank you, Dr. Doshi. Excellent, very informative lecture and very, very practical. And this magnesium sulfate is so much, neuroprotective, everything, but it is really irony of the situation that it is not being used. But here I will like to add one more thing. When I was a Deputy Director, Health Services, Family Welfare, that time, there was a government resolution has come. It was way back in 2007-8 that the ANM, that time ANM are empowered by GR. This thing has come. Order of the government has come. Those working in the primary health center or the rural hospital are empowered to give the MGSO4, and they were trained for 1 or 2 days how to make it, how to do it, and after prevention of neuro, this thing first, how to shift the patient. That much training was given to them. So I think that is a good initiative on the part of this our government, that at least they are empowering the nurses, and so that the early doses can be given and later on they can shift it to the. So I think so. Thank you very much for enlightening us for.
Yeah, just 1 or 2 comments. I wanted to say that nowadays we have those ready-made 100 ml bottles. So it has actually, it's now much easier to give the Maxsulf in the correct dosage. And another thing, Dr. Saab, I wanted to ask you one thing. Like in our time when we were doing PG, we were told that for neuroprotection of the premature babies, we should use the obstetric outlet forceps and give a big episiotomy. Now, what would your say on that be? Is it actually beneficial? They said it will protect and it will not cause ICH to the baby. But I believe that it has to be correctly applied. That is most important. Because if you wrongly apply the outlet forceps, then the baby as it is going to have ICH. So yes, what's your take on that, sir?
Yes, you are right, madam. Right. In my books also, that is now books is 16th edition, because I started writing in 1985. Initial edition of the book I wrote is a protective, right, use of the forceps. But then the literature came also that for preterm baby, right, it causes compression, causes more problems, sometimes ICH, because the capillaries are fragile and should not be used. Never vacuum. Never vacuum.
Never vacuum. Only the release outlet.
This also people thought that because it's the first type of liver, it blocks and the excessive compression of the maternal pelvis or soft tissue will not happen. But the baby is premature. The head is not that much big size. So that from maternal soft tissue compression injuries is not there. So whatever compression injuries will happen with the forceps is traumatic. So it is not indicated for protection.
Yeah.
But if preterm babies have a distress, you can use it. Don't use vacuum.
Yeah, actually, we never, in my mind, because I was purebred obstetrician. So I used to always think that this is going to cause more trauma to the fetal head. But we were told, no, this child is premature. You have to just see the rotation of the head and apply the forceps.
It was there
and
for
then give a big episiotomy and take out the baby without trauma.
that belief and notion was there for a few years, then it stopped. Now nobody is looking for protection.
Yeah, this is one thing I wanted to clarify.
Yes, madam.
Thank you very much. Yeah.
Thank you,
Thank
Dr.
you so
Harish
much,
Doshi, sir.
sir. That was a wonderful talk.
Thank you, madam.
Thank you. Thank you, Dr. Harish Doshi, sir. It's
I
always
have
a
to
pleasure
tell
to
one
have
thing.
you. Yes,
I have
sir.
to tell one thing. When Pratik calls you, you have to be very accurate. He is also very precise in everything. So I have to prepare my talk and then come to the webinar.
Thank you, sir, for being here. It's always a privilege to welcome you on the Amox platform. It's always wonderful to listen to you because you are one of the legendary teachers. There are very few of these old timers and the grand old men, as we used to call them, left. And it's always a privilege to listen to you, sir. With so many decades of experience, you've seen so many things.
Yes.
Every time you speak, even I learn something new from you.
Oh,
Thank
great.
you for being here.
Of course.
Thank you. Thank you.
Can we have the CV slide of Dr. Ranjana Khanna, ma'am? She's already participated very actively in the program so far, but we have not formally introduced her. Dr. Ranjana Khanna was the Vice President of Foxy in 2017. She is the Founder President of the Prayagraj chapter of ISOPAB. She is, of course, currently a Governing Council member of the ICOG. Along with me, she was a President of the Allahabad Society 2013 to 16. Also served the same society in various other positions, including Honorary Secretary, Treasurer. She's organized so many conferences in Allahabad, both during her tenure as Vice President, before and after that period as well. She's won several awards, including the Foxy Veera Award in 2022. For the Allahabad Society, she has won the BK Tank Reproductive Healthcare Promotion Trophy in 2015, the Smriti Mailan Award in AICOG 2013, and several other felicitations awards to her credit. We are also delighted to welcome Dr. Parag Biniwale, sir, the the Vice Chair of ICOG. Sir was held up in an emergency and therefore joined late. And I hand over now to Dr. Ranjana Khanna, ma'am, to introduce our next speaker.
Yeah, it's my pleasure to introduce Dr. Parag Biniwale. He is a senior consultant, OBGYN Pune. First of all, he is Vice President of ICOG, Vice Chair of ICOG, Unit Head and PG Teacher, Kamla Nehru Hospital, Secretary ICOG. He was in 2018 to 2020, President of the Menopause Society, Pune, National Joint Secretary, IMS, National Website Editor, Foxy, Peer Reviewer, Journal of OBGYN, Chairman, Young Talent Promotion Committee, 2008 to 10.
That's enough.
That's
Don't
enough.
waste time in that.
I think everybody knows you very well. And we are looking forward to hearing from you on preterm labor.
Yeah. Thank you. Thank you, Dr. Ranjana, for those kind words. I bring greetings from ICOG, and it's indeed a pleasure to be part of this program. First of all, let me thank the office bearers of AMOGS, and particularly Dr. Pratik Tambe, who heads the endocrinology committee of AMOGS, for considering me for today's presentation. And thank you, Harish Bhai, for allowing me to change the sequence as I was held up in an emergency. And
yes, sir, please.
Yes, it's very heartwarming to see the three of you, because you are my governing council members in the ICOG, and of course, Dr. Meg is the past chairperson of ICOG. In next 20 minutes, I'm going to talk about one problem which really bothers all of us, and it keeps on bothering us, because let's not forget that we are the most populous country in the world now, and then we are going to face the problems of preterm labor, and then we have to be really well equipped to manage preterm labor and preterm birth. All of us know that any delivery that takes place before 37 weeks of gestational age is labeled as preterm birth, but it is estimated that 1 in 10 babies are born too soon. It is also estimated that 15 million births take place much earlier than the expected date of delivery, and 1 million plus babies die because of the consequences of prematurity. And of course, we are one of the most important contributors to prematurity and preterm births. Well, we are aware about the mortality aspect, but let's not forget the morbidity that is also associated with prematurity. Dr. Haresh has very nicely talked about one small intervention which can help save life of a patient, and of course we do get a better neurological output, but respiratory distress syndrome, necrotizing enterocolitis, and sepsis, apart from intraventricular hemorrhage, are the reasons why these babies suffer and even die. So when we talk about preterm labor, we should be well versed with the factors which are associated with preterm labor. Traditionally, we know that overdistended uterus is likely to be a reason for preterm labors, and multiple pregnancy contributes to it. Of course, we know that fertility treatments are the ones which are responsible many a times for multiple births. Previous history of preterm birth is something which is extremely important, and this is a deciding factor when we think of managing any patient in preterm labor. Maternal stress, previous trimester miscarriages, PPROM, infections, smoking, etc., do contribute to preterm labor to a certain extent. So these are the risk factors which we must keep in mind. So taking good clinical history is of great importance. Short cervix is something which we have to be vigilant about, and the presence of any risk factors that can be considered as a trigger for screening of cervical length by a transvaginal ultrasound scan. So whenever any pregnant patient, say in the 7th or 8th month, comes to us with symptoms like menstrual-like cramping, mild irregular contractions, low backache, or even pressure sensation in vagina or vaginal discharge, please don't ignore it, because we may be dealing with a woman who is in preterm birth, and we may lose an opportunity to arrest the preterm birth in order to have a better outcome. Initial evaluation is extremely important. So we must estimate the correct gestational age, look at her reports, find out the exact gestational period, and then start intervening. The next question is, has the labor begun or is it imminent? Because this will definitely guide us as to how aggressively we need to manage this particular patient. Is early intervention indicated? So here we must rule out maternal issues like medical disorders or chorioamnionitis, or if the fetus has issues like abruption, infection, abnormal CTGs, or even cord prolapse. And of course, fetal presentation is extremely important because it will guide us if the patient is in established preterm labor. So these are the important points we should not miss, and they do have an important role to play in diagnosis and planning a management for preterm birth. Ultrasound is a game changer, I would say, as far as preterm labor is concerned, because when we assess a patient with a good ultrasound, we of course come to know about the cardiac activity, number of babies, presentations, estimated fetal weight, status of amniotic fluid, biophysical score. So all these factors will help us in deciding the further course of management. And this is what is an approach to a patient who is suspected to be in preterm labor. So depending on the gestational age, we will take a call. If the gestational age is more than 34 weeks, literature supports that there should be no tocolysis or antenatal corticosteroids. We should admit the patient, and if the labor progresses, but if the contractions cease, we may think of discharging the patient. Now, if the duration of pregnancy is less than 34 weeks, we need to assess the patient about cervical dilatation. Now, if the cervical dilatation is more than 3 centimeters, so preterm labor is likely to be there, and then we can offer tocolysis. We should give antibiotics for GBS prophylaxis, more so in the Western countries, not very commonly practiced in our country. Dr. Haresh has already talked about magnesium sulfate, and of course, antenatal corticosteroids if the duration of pregnancy is between 23 and 34 weeks. If the clinical examination, the ultrasound examination for cervical length diagnose that the preterm labor is unlikely, we should observe the patient. Women without progressive cervical dilatation and effacement are discharged at home. We should keep a good follow-up. Of course, the patient has to be counseled that if she experiences any discomfort, pain, unusual discharge, she should come down to the hospital immediately. Preterm labor is unlikely if then the observation is needed for 4 to 6 hours. Women without progressive cervical dilatation and effacements are discharged at home. Call the patient after 1 or 2 weeks for a follow-up, and she must report if there are any unusual symptoms. So we refer to these guidelines, and of course there are newer ones, and the main class of drugs which are used for management of preterm labor are the tocolytics. When we talk about tocolytics, the beta agonists, isoxsuprine and terbutaline are the ones which are most commonly used in our country. Calcium channel blockers like nifedipine is very much there, and it is being used for this particular indication for a long time. Magnesium sulfate, Dr. Harish has already talked about. Nitroglycerin, which is a nitric oxide donor, has been noted in some of the studies as a good tocolytic agent. And the oxytocin receptor antagonist, that is atosiban, is the relatively new kid on the block, which is used for arresting preterm labor. So the question is, which agents should we use? So the most popular agent throughout the world are beta agonists. All agents will produce some kind of effects and side effects. So the clinical effect that we look at is cessation of labor pains, and some of them will not be useful in some women. But in general, it is found that nifedipine and atosiban are supposed to be safer than the beta agonist. The next question is, till when tocolysis should be continued? So we should allow the steroids to act. We should allow the intrauterine transfer to a higher center, and then we can consider stopping tocolysis, which typically is around 48 hours. There is little or no benefit from follow-on tocolysis after an episode of preterm contraction has subsided. Atosiban, now it is given in a drip form, and this is how it is given. The IV bolus dose is given where it's a 6.75 milligram vial, which is given intravenously in an infusion bag over 1 minute. And then a continuous maintenance drip can be continued for about 48 hours. Nifedipine is the one which is extensively used. And when we start it, we give a stat 20 milligram oral dose. A repeat dose can be given after 30 minutes, another one after 30 minutes, and then 8 hourly for 48 to 72 hours. Please note that maximum permissible dose for nifedipine is around 160 milligrams in 24 hours. There are quite a few studies which have researched about nifedipine as tocolytic, and they have concluded that nifedipine is safe and effective in prolonging preterm labor and has minimal maternal and neonatal side effects. It eliminates the need for intensive maternal monitoring as required in cases of beta mimetics. We had one study, which it was a thesis submitted by one of my students earlier, where we did continue nifedipine for a longer duration of time. There are a few studies which talk about a maintenance therapy, though not very commonly practiced, but we were able to achieve a prolongation of pregnancy by about 2 or 3 weeks, which hopefully was beneficial for the babies. When we talk about safety of currently available tocolytics, we know that beta mimetics should not be used in women who have cardiac arrhythmias, poorly controlled thyroid disease, and diabetes mellitus. We must keep a watch on the maternal side effects, which would include cardiac arrhythmias, pulmonary edema, hyperglycemia, hypotension, etc. And the neonatal side effects are also there, which have to be, one has to be vigilant when we are using it. Nifedipine is contraindicated in women who have cardiac disease. We must use it with caution in women who have renal impairment. There are certain maternal side effects like headache, dizziness, flushing, etc. We should be worried about. And then literature reports neonatal effects in the form of sudden fetal distress and fetal demise. Indomethacin, ketorolac, etc. have been used in some cases. They do have significant renal or hepatic impairment, so should be avoided in such women. Active peptic ulcer disease, coagulation disorders, thrombocytopenia, these drugs are better avoided. Coming to isoxsuprine, now all of us have used isoxsuprine for umpteen numbers of years, and it is used in a dilute form. So we usually add it in 500 ml of 5% dextrose or DNS or even ringalactate. The drip rate has to be as per the contractions. We have to monitor the blood pressure, and here we must remember that it's a potent vasodilator. It has DCGI approval. ACOG does recommend beta-sympathomimetics as first-line therapy in the management of preterm labor, but this is something which we should be vigilant about. And this is the lead one study which is from Bijapur in Karnataka, where they did use isoxsuprine in about 50 women, and they concluded that isoxsuprine was found to be an effective and well-tolerated tocolytic agent in arresting preterm labor, in turn resulting in the overall improvement of maternal and perinatal outcomes. So this was a study published in 2021. Somehow, in spite of its extensive use, we have switched to nifedipine for last 15 years or so. I'm not going to talk about neuroprotection. We've heard a fantastic lecture by Dr. Haresh Doshi about it. But what we must emphasize on is preventing preterm births. Now, we know that there could be certain risk factors, and the cervical screening is something which is a good pointer for prediction of preterm birth. So these are the recommendations of SMFM given in the year 2016, and they recommend a routine transvaginal cervical length screening for women with singleton pregnancy with history of spontaneous prior preterm birth. They also recommend a transvaginal screening not to be performed for women with cervical cerclage, multiple gestations, PPROM, or placenta previa. They recommend practitioners who decide to implement universal cervical length screening to follow strict guidelines, and the SMFM recommends sonographers and practitioners receiving specific training in acquisition and interpretation of cervical imaging during pregnancy, because unless we have a good imaging of the cervix, we are not able to predict and treat preterm labor in time. So progesterone is something which has been extensively studied and used for prevention of preterm births. Now, the recommendations of the SMFM in the year 2012 do hold true even today. So what they recommend is in women who are asymptomatic but with singleton without spontaneous preterm birth and unknown or normal transvaginal ultrasound cervical length, there is no evidence of efficacy, so they do not require any progesterone. Singleton with prior spontaneous preterm birth, 17-hydroxyprogesterone caproate 250 milligrams weekly up to 36 weeks of gestation. Singleton without spontaneous preterm birth but cervical length less than 20 millimeters at 24 weeks. Vaginal progesterone 90 milligrams gel or 200 milligrams suppository daily from diagnosis of short cervix until 36 weeks of gestation. Multiple gestation is something where researchers have found progesterone has no role in stopping or preventing preterm birth. And in symptomatic women, nothing really works at times. But here we have to be hopeful that whatever treatment that you're offering does well for the patient. So which progesterone? We do have quite a few options. The vaginal suppository or vaginal pessary is something which has been extensively studied. It is generally well tolerated. It gives a good plasma and tissue concentration, and it is also found to be effective. Let's not forget the 17-hydroxyprogesterone caproate injections, though there is now some advice against it by the Americans. In India, we do not have any specific guidance about its use, or rather stoppage of use. The oral progesterone generally doesn't work that well, but there are claims that the sustained release preparations do work well as far as arresting preterm labor is concerned. My preference would be to offer a vaginal progesterone or to give intramuscular injections of 17-hydroxyprogesterone caproate weekly. There are quite a few studies which do talk about progesterone vis-a-vis cerclage, vis-a-vis pastry for preventing preterm births in singleton pregnancy. And what they found out was progesterone was the best intervention for preventing preterm birth in singleton pregnancies at risk, reducing preterm births less than 34 weeks and less than 37 weeks, reducing neonatal demise and other sequelae. So it really makes sense to use progesterone in order to prevent preterm birth. So if we can prevent something, why not make a full attempt to do so? The controversial area is multifetal gestation and preterm birth, because we are really confused about treatment. If you look at the literature, nothing works in preventing preterm labor as far as multiple gestation is concerned. So 30% of triplet pregnancies will deliver before 26 weeks as compared to 8% of pregnancies where triplets are reduced to twins. So it makes sense to counsel the patient who has conceived with a triplet to think of reduction, and with good fetal medicine specialists around, the success rates are much better. So the risk of MFRP from twin to singleton are greater than its benefits. Vaginal progesterone for prevention of preterm birth, and this was a randomized trial of safety and efficacy published in the year 2016. Administration of vaginal progesterone to reduce asymptomatic women with a twin gestation and a sonographic short cervix in mid-trimester reduces the risk of preterm birth occurring at less than 30 to less than 35 gestational weeks. It also reduces neonatal mortality and some measures of neonatal morbidity without any demonstrable deleterious effects on childhood neurodevelopment. So this is something which is really important, because we are looking at a good outcome without harming the baby. And these are the recommendations of progesterone supplement to prevent preterm births. These are very much available on the net, and these are the ACOG recommendations. Emergency cerclage also has a certain role to play. We know that it is a procedure where the cervical dilatation is very much present. The membranes are many times exposed to the vagina. It is definitely less effective than prophylactic, but it's a desperate attempt to arrest preterm birth. But let's not forget that there is increased possibility of rupture of membranes during and after the procedures. So we must rule out infections, contractions, and also rule out rupture of membranes. The addition of tocolytics and prophylactic antibiotics increases the efficiency of the procedure, and it definitely has an advantage over the no stitch group. Of course, many of us are putting a womb stitch or even a modified McDonald stitch as an emergency procedure. Steroids are something which are the saviors. So dexamethasone 12 milligrams, 2 doses repeated after 12 to 26 hours or betamethasone 6 milligram 12 hourly 4 doses. It is indicated in all the patients where we are contemplating preterm birth. One course or repeat course, there was a time where we used to repeat steroids every week, but that is no more true. So just a single dose, and if it is given before 28 weeks, we may consider another rescue dose just before thinking of a preterm delivery. It should not be used in women with chorioamnionitis, and it has umpteen benefits rather than risks. In case of PPROM, we have to be really vigilant because we do have certain tasks to fulfill. Infection prevention is an important aspect, so no repeated PVs, use of judicial antimicrobials is important. Enhance lung maturity, take a decision whether continuation of pregnancy is safer or not, and close monitoring is extremely important, which includes hemogram, CRP to be done every 48 to 72 hours, and serial ultrasound and Doppler generally repeated every week. Coming to antibiotic therapy in PPROM, so here we should look at the benefits which are there with antibiotic use, especially when we are thinking of prolonging pregnancy, and it definitely reduces major neonatal morbidity caused by infections. Which antibiotics? Typically ampicillin 1 gram every 8 hours for 48 hours, followed by erythromycin. Of course, there are studies which talk about azithromycin in the dose of 500 milligrams daily to be continued till the pregnancy is continued. Cephalosporins are, of course, important. Coamoxiclav is something which is a strict no-no because we are always worried about an increased risk of necrotizing enterocolitis. And decision-making in preterm birth is something which we have to be weighing because preterm PROM poses a lot of challenges. So if you decide to wait, it should be for the fetal maturity, for the corticosteroids to act or the antibiotics to cover the infection, or if you are thinking of in utero transfer. Well, there are certain reasons that are required to intervene: onset of labor, acute complications, and preventing fetal complications in order to have a better outcome. So it also depends on the neonatal intensive care unit availability and the parental wishes, because if you are thinking of in a particular direction, parents may not be on the same line, so their opinion also matters. And here the fetal well-being has to be particularly managed. The gestational period and maternal conditions are extremely important. So when you're delivering the preterm fetus, there are certain points that we must keep in mind. Whenever you're performing a C-section, there are challenges. Deciding the route of delivery also is a critical decision, and here counseling of the patient and the relatives is extremely important. So whenever we are delivering preterm babies, it has to be a balanced decision for intervention. Cesarean section does not necessarily improve the neonatal outcome. So whenever you are contemplating a vaginal delivery for a preterm baby, the care has to be optimum. Electronic monitoring is desirable. Antibiotic cover has to be given. Atraumatic delivery is something which we should aim at, and presence of neonatologist is extremely important. And performing a C-section is extremely difficult because here we have to remember that the lower segment is generally unformed or poorly formed. There are extensions possible. Bleeding is generally more, and these are poor surgical risk candidates, and one has to be really careful with a presence of senior obstetrician. What are the indications for cesarean delivery in preterm births? Abnormal presentation, breech, transversal, etc. C-section is prudent. Acute complications before or after onset of labor, C-section has to be a low threshold decision. And failure to progress, where you are attempting a vaginal delivery, and if it doesn't happen, one has to resort to C-section. And these are some of the important points that we should remember whenever we are thinking of C-section in premature babies. This is one app. I have personally not used it, but I've read about it, which talks about the evaluation of impact of triaging women who are at risk of spontaneous preterm births. It incorporates a predictive model with women with history of spontaneous preterm birth, gestational age, and quantitative measurement of fetal fibronectin. It gives us accurate assessment of risk of threshold of preterm birth, avoiding unnecessary admissions, and we are able to manage these patients on an OPD basis. So to conclude, preterm birth is a preventable problem, and we have to go all out to achieve it. Vigilant monitoring and aggressive treatment is essential. Progesterone, especially the natural micronized progesterone and 17-hydroxyprogesterone caproate, have important role to play in prevention of preterm birth and should be offered to women where we are contemplating a preterm birth based on history. So we would prefer to start it at around 16 weeks in order to prevent it. Tocolytics have an important role to play in acute preterm labor where we want to stop the contractions. Steroid administration is a vital aspect of preterm birth and management, and cervical cerclage has its own role to play in preventing preterm birth or treating preterm birth as an emergency procedure and should be used judiciously. So thank you very much. And once again, thank you, Pratik, for giving me an opportunity to talk about preterm labor.
Dr. Parag, that was a absolutely complete presentation. I was, trying to find some loophole, that I could point out, but there was none. So you have actually spoken everything. And I think actually we get very good results with isoxsupreme because we were using it in our initial days, and now also I am seeing very good results still with it, and progesterone is our lifeline. So and if a patient comes at 36 weeks, would you like to give steroid?
That is a controversial area, but I would still give it. If you refer to the RCOG guidelines, what they say is if you are
probably some internet issue.
Yeah.
Even the RCOG guidelines recommend that at 37 weeks, if you're doing an elective cesarean section, even then in that case, you do give a steroid.
Yeah. They are saying actually, now it is said that before 39 weeks, whenever the patient is delivering, you should give, because actually there is no harm in giving, I feel.
Absolutely.
It only benefits, and it saves so many NICU admissions.
The incidence of transient tachypnea of newborn PTN is significantly lower, and even at 37 weeks, the incidence of PTN can be 1 to 2%. And as Dr. Ranjana Khanna rightly pointed out, NICU admission will significantly decrease.
Significantly reduced. So the pediatricians are like, "Oh, acha, you gave the steroid coverage, so fine, the baby is fine."
So Dr. Parag is back with us.
There was an electricity failure, so suddenly, I went offline. Yeah, see, RCOG talks about giving steroid before, if you are doing an elective C-section before 39 weeks of pregnancy.
Yeah, 39
so I
weeks.
personally feel that we should give it. It doesn't cause any harm. And
I give it to prevent NICU admissions.
NICU admission, and then even transient tachypnea of newborn is taken care of. So I mean, we give it routinely, even if it is 35 or 36 weeks.
I feel sometimes there's a slight error in the gestational age estimation also. So this covers it. Now, if we have given steroids, so the baby does not suffer.
Absolutely. And we should not, it is such a simple intervention without any harm. We should offer its benefit to our patients.
Yeah.
Because the NICU admission, the morbidity associated with it, even the financial morbidity that is associated with NICU
NICUs are very really expensive nowadays. NICUs are most expensive. So it is. Acha, another thing I wanted to say was that nifedipine causes very horrible headaches as side effects. So I don't give it to my
So
patient.
we've switched over to nifedipine about 15 years ago. Though for acute preterm labor, isoxaprine is still it works wonderfully well. I would certainly like Dr. Haresh also to give his opinions regarding this. But then you have to counsel the patient that nifedipine is likely to produce headaches, and typically, if you notice it, it is very much there in 48 to 72 hours, and generally then it subsides, or possibly the patient gets used to it. So she doesn't complain
No,
of
you can't
headache.
get used to those severe throbbing headaches.
In any case, I think we have to remember that nifedipine being used in preterm labor, which is endorsed by the ICOG guidelines, it's an off-label use of nifedipine. That's not the way the original manufacturer
Yeah,
intended its usage. India
mainly for
traditionally has been
hypertension.
isoxaprine country, and I think
Yeah,
we are all very comfortable
yeah,
with
we
it.
are
We have
very
grown up
comfortable with the
titrating
isoxaprine.
those drips in our younger days,
Yes,
and
We
we have
should
passed
endorse
that
our
on. And
right.
we'll pass it on to our juniors as well.
We should
Dr.
accept
Haresh,
and endorse.
Dr. Haresh, how many ampules of duathlon you put in that?
Madam, no
Four,
trade name.
Four.
not 10 ampules, 4 ampules.
Four. Then
Okay.
we usually start with, I mean, for acute preterm labor, we usually start with 40 milligrams and then, try and reduce it.
Yes, correct.
Yeah,
But then, even today, we don't give it beyond 48 hours. I mean,
no.
Yes.
Normally the pains do subside or she delivers, either way.
So that brings us to the Q&A session, and there are only 2 or 3 questions which are relevant. Most of them have already been addressed by, I think, very excellent speakers. The first question is from Dr. Ila Agarwal from Mathura, and I think this is for Dr. Haresh Doshi sir. Does the risk of atonic PPH increase if you administer magnesium sulfate? That's what she's asking.
No, with this dose, right, there is no risk of atonic PPH. We've been using it for preeclampsia, as well as the tocolytic effect itself. So no risk of atonic PPH, right, has been found also in studies also that this is not increased. It's a theoretical.
I'm just sharing my screen because I want to show one very important slide, because there is a relevant question. And the question is, what strength? 25%, 20%, 50%, what should be the dilution of magnesium sulfate which should be used? So the short answer is, there is now a ready-made solution which is available. That's 4
Yeah.
grams in 100 ml. The trade name I'm not supposed to take during a program, but since they are our education partners for this particular event, I will tell you, it's called IVMAG. It's very easy to administer. You just set this up with an infusion pump, and you can give this slowly as a bolus over 15 to 20 minutes. And the next pint of 100 ml you give at the rate of 25 ml per hour for the next 4 hours. As Dr. Harish Doshi said, that it takes only 4 hours for neuroprotection. So you will need only 2 small 100 ml pints. It's a totally no-brainer situation. You don't need to worry about 20%, 25%, or 50%. All you need to do is adjust the drip rate if you don't have an infusion pump. If you have an infusion pump, then that will do your job completely for you. It's the first pint of 100 ml to be given over 15 to 20 minutes and repeating. The second pint of 100 ml at the rate of 25 ml per hour for the next 4 hours. So that's it. Short, sweet, and simple. It's an absolute no-brainer. Even in periphery, in a primary health center, when there are paramedical staff, there are no doctors around, or the doctor is on leave, there's only one clinician attached to that primary health center. This is going to be a boon and is going to help not only in cases of preterm labor, but obviously in cases of eclampsia as well.
Also,
Where there is no proper hospital to take care of that patient. And that first dose of Maxel is the one which is going to save the patient's life.
Yes.
There is one question from Dr. Mithun Sarkar, and I think this has already been addressed, the role of magnesium sulfate in protection, we talked about. And Dr. Monica Agarwal has just put in a message. She's from Mumbai. In GDM patients, we usually deliver at 48 weeks. Should we give steroids and it may be below sugar? I think this is in response to the discussion that we just had a few minutes back.
Even in GDM, whenever we are thinking of preterm birth, it is prudent to give steroids, monitor sugars closely. If she is GDM on medications, then ideally she should be admitted and then observed for next 48 hours with close sugar monitoring. And the insulin doses need to be adjusted depending on the sugar.
Correct. It requires to be increased by 4 units average. When patient is already on insulin, we have done this, but we always give.
Yeah, and if the patient is controlled on diet, then generally nothing is required.
Nothing.
You just have to counsel the patient for after administering steroids, she may perceive less fetal movements for next 24 to 48 hours. Because this is the general observation which we come to know from the patients themselves. So
And
this is something which we have to.
And even if it increases little sugar, in our branch, we always weigh the benefits with risk. The benefits of steroids is too much. So risk, little increase in sugar, no problem.
Yeah.
At the end of the Q&A session, I would request all our eminent faculty to give any closing remarks. I was trying to get in touch with Dr. Munatini Meg, madam. I think she's been called away to an emergency. I still see her logged in. Yes, madam, we were just talking about it.
Hello.
We would welcome some closing remarks from you, ma'am, here at the end of our.
Hello, Dr. Pratik.
Yes,
So, Parag, excellent lecture. I was busy with some other webinar also, but I could hear. And thank you very much for inviting us for this wonderful program. And wish me good luck, all my ICOG. Everyone is ICOG here.
All the best, all the best.
Thank you. Wonders in the Foxy, once elected.
Any other closing
remarks? I was telling Dr. Meg that she did a lot for the governing council members when she was the chairperson.
I was telling them that you should keep on award. Parag and we have instituted that award. That gives a lot of motivation for the governing council to work, because they compile their work, they keep on doing good work, and that is an involvement. And everybody, Sampath Kumari till today shows that trophy of first award she received. Then Archana Baser third award, Sarita Valera second award. It is such a prestigious thing to have that award. And you people are already doing so much. I think I told Lakshmi this year you must institute that again, start the award which I have started.
Yes, ma'am.
Okay then.
If she doesn't, I will again restart when I become chairman.
Parag will definitely do, because everything was done, me as a chair and he as a Parag.
There was another thing that you had to do, Parag, which you promised that you will do when you become the chair.
What is that? What is that?
Even I told him that why doesn't if I am doing a program for ISOPAP, why can't I get ICOG points? No, listen, ma'am, first. So, because basically ISOPAP also has FOXY members only. So, but he said, no, this is not the norm. But when I become the chair, then I'll get it done. So that is why I'm reminding him. And anyway, I love to log on with other societies of FOXY, so it's fine.
For any policy to make, you have to look from many angles. There is a ISAR, there is IEG, there is everything. They just want to put the logo and not give any respect
so I think
to ICOG. So
we will stall this political discussion for now while I present the vote of thanks, because we are still live and we are on air. May I remind everybody?
One thing I would like to say in the end is that prematurity and preterm birth is always a cause of concern. And one thing that we have to be very careful about is the gestational age. And for that, the first ultrasound is the one which is of utmost importance. So at least I am relying most on the first ultrasound. And then according to that, you calculate the date, because often it is very confusing whether we are going to, whether the baby that's coming out is going to be absolutely preterm or the child is going to be FTND, I mean normal delivery. It should be fully normal and term baby rather. So this we have to be very careful in judging what is preterm and what is not preterm. And of course, neuroprotection is very important, that Dr. Doshi has already told us, and everything else Parag has told us. So
thank you, Dr. Ranjana Khanna, for that important point about dating ultrasound, especially the interiors of patient don't register until the 7th month. There is no ultrasound. Very
yes.
important to have the dating scan in the first trimester. So I'll close today's event as the convener by presenting the formal vote of thanks. This is Dr. Pratik Kamble. I'd like to place on record my gratitude to the among office bearers, our beloved President, Dr. Rajendra Singh Foundation, Secretary Dr. Sudhakar Ravi. Thank you for your blessings and for allowing us to conduct this experience series. Today's program was on preterm labor and specifically protecting the at-risk fetus. We had two eminent stalwarts, Dr. Haresh Doshi sir as the first speaker, spoke on the role of gender protection, and we had Dr. Parag Vale sir, Vice Chair of ICOG, who spoke on treatment of preterm labor in general, an exhaustive presentation covering the history, geography at length and breadth of preterm labor. Two fantastic stalwarts, Dr. Mannati Umek, the past Chair of ICOG, and our candidate for proxy president. Thank you for gracing the occasion. She was also incidentally my non-civil coordinator in charge because I report to her directly. And Dr. Ranjana Khanna, our past Vice President of Proxy, current Governing Council member of ICOG. Also, I must acknowledge the ICOG office bearers, Dr. Lakshmi Pandit, the Chairperson of ICOG, Dr. Ashok Kumar, the Secretary of ICOG. Thank you for the ICOG credit point for today's event and all other events in this series. Our scientific backbone, Science Integra, Subhu and Shrutika, who is newly joined. Thank you for being here with us for this program. And last but not least, our education partners, listen, makers of I3, Carbesin, and IEMAC. Thank you for being our education partners throughout this year, for bringing these valuable programs to our audience. We have an audience of nearly 700 who have logged in live, despite it being a scorching hot afternoon in India. It's 45 degrees in Bombay. Thank you very much for logging in, and we hope to see you in the next event. Until next time, goodbye. God bless. Thank you.
Bye-bye.
Thank you.
Bye. Thank you.
One small thing,
Yes,
just
ma'am.
the report of your activities. I have to
Yes,
present.
ma'am. I will send you. I will send you as soon as it's compiled. You can take us off air, please. Thank you.